Hello and welcome to Friendly Pharmacy 5. Today I have Dr. Glen Pyle with me. Dr. Pyle, thank you so much for taking some time out of your busy day to talk to us a little bit about heart health and specifically women's heart health. Before we get started, could you tell us a little bit about what you do right now, what your day-to-day looks like, and how you ended up studying women's heart health specifically?
Sure. So my day-to-day is I'm a professor of biomedical sciences, and so I spend some time still working in the lab, but that's what I trained to do. So I still like to go in the lab and do experiments. There I'll supervise grad students and staff. I also teach a fourth-year cardiology course, and then try to do as much outreach as we can, both for cardiovascular, but science and medicine kind of in general. This is an increasing part of our job, and I think it's something that we as researchers and scientists need to do more of. How I came to this point, I think like a lot of academics, like a lot of researchers, it's I guess by accident. I'm what they call a first generation student, or I was a first generation student, which meant that no one else in my family had gone to university before. So I didn't really know what to expect. I mean, I knew I wanted to do science and I had some ideas, took some careers I wanted to pursue, but I really didn't understand the academic system, after you're thrown into it as a student. But I got to know some of my professors in my undergrad, and I think that was a huge influence on me choosing the career I did. They explained the job that they did, which is not what I thought it was. And I really liked the idea of coming into the day and not necessarily knowing what was going to happen that day. I mean, with medicine, you have patients and they come in and they may have surprises for you. But with research, you're truly breaking new ground. If you're discovering things that or finding out things that people already know, you're not really doing research. So I was really excited to be able to do that. And I just sort of moved through my undergrad, and it wasn't until the fourth year I thought, well, maybe research is for me, and jumped in, and I haven't looked back.
That's fascinating. And how did you end up doing research in the area of women's cardiovascular health? How did you fall into that?
So that was actually an area I was interested in right off the bat. So I went to grad school many years ago. It was in the mid 1990s, and it was really when we were starting to recognize that women were at risk for cardiovascular disease. And I know that sounds crazy now, but when we think back to the 1980s, 1990s, things like that, if you had someone who had a heart attack, if you asked somebody to picture somebody, they would think immediately it was a man, it was an older man.
Right.
No one really ever thought women could have heart attacks, and clearly they were. It's just it wasn't really widely known. And then as I started to go through university, you discover that women were at risk. We're discovering these new things about women's heart health. The idea of using estrogens to, I'll say, treat women. It was really to prevent cardiovascular disease was just really coming to the forefront. And so I was excited by that. I found it very interesting to study how men and women differ in cardiovascular disease. And actually, when I started grad school, that was the idea I pitched. I said, "This is what I want to do," and everybody said, "Yeah, we already know that, right? We know estrogens are protective. We know if we give them back to women, everything's fine." It's like, okay, so I moved on to other things. I'm still working in cardiovascular, looking at heart attacks and things like that. And then in the early 2000s, when some of the clinical trials, which had previously shown that estrogens were protective of the cardiovascular system, started to show that there was actually risk potentially associated with these hormone replacement therapies. And really what that uncovered was the fact that we actually didn't know how estrogens work, and we actually didn't really understand how the cardiovascular system, in particular cardiovascular disease, manifests or works in women. That cardiovascular disease in women is not the same as it is in men. And again, saying that now, people say, well, that's obvious, but it wasn't at the time. And it was largely because no one had ever bothered to ask that question. So this was early in my academic career, and it really opened up an area where, like I said before, I could go into research and do something that no one had ever done before. No one had asked these questions. And so it really became a wide open field, but an area in which you could have impact. because we knew so little, but we knew the risk was so large that really any information that we were able to gain could be helpful. So, it was very exciting to get into this area, and we have a purpose for doing what we're doing.
Was it challenging to get funding for your research? Did organizations see the importance of this research at the time, or how has that been for you?
Some do, some still don't. Some of the funding agencies were supported right now by Heart and Stroke Foundation of Canada.
Mm-hmm.
They've set aside money specifically for women's heart health. And they've done this because women have really been underinvestigated for a long time. And even now, when we recognize the unique risks that they face, there's still not a lot of research into that area. There's not a lot of treatments that are geared specifically towards women to treat their unique circumstances. Because, like I said, it's not the same as in men. So, heart and stroke was very early on this. Canadian Institute of Health Research, CIHR, which has also funded our research, has also set aside some money. So they've been very good at directing money towards this problem, people, supporting people. We've hosted meetings in Canada looking at this. There's an annual meeting looking at women's heart health. So there's been a lot of support there. There's still some pushback on things, people not either recognizing or acknowledging that women are different, right? That the treatment that you give to a man is not necessarily the treatment you should give to a woman. I'm not sure why that is. And other people still, or organizations still, think that it's not a priority, that there's not a lot of women who die of cardiovascular disease. They're more likely to die of cancer or something like that. So really, we should invest money elsewhere. The fact of the matter is cardiovascular disease is a leading cause of death for women worldwide. So, we just need to provide more education and just keep making our case. But by and large, I think there's been some really important groups that have been behind us since the beginning, and not just us, but researchers across Canada as well.
Yeah, and you mentioned some of maybe the misconceptions or the I guess just the way of thinking about cardiovascular health that still maybe exists somewhat today, and it sounds like maybe that's changing somewhat. Are there any other general misconceptions that you see, maybe even among healthcare professionals or among the public? You mentioned a couple of them already. Are there any others that you constantly bump up against, and it's like, you guys, this is not true at all, or anything that comes to mind?
So for women, it's the idea that women are at low risk, and in fact, they're at high risk just the same as men. Certainly, earlier in their life, they do tend to have a lower risk.
Mm-hmm.
I think what people may not appreciate, and this is actually research that's just come out over the last couple of years, is when they looked at different groups of people, different demographics, to see who's at greatest risk for cardiovascular disease and dying from cardiovascular disease. Certainly older people are at risk. We know age is a risk factor. I think people are recognizing more that older women, and by older I mean generally women over 50, which is post-menopausal, have a higher risk. What they may not know is that the risk, for example, of dying from a heart attack is greater than that of a man.
Mm-hmm.
After 50, that's what happens. The other thing I think that very few people appreciate, and this may be a sign of things to come, is that the fastest growing group for deaths from heart attack are women under 35. So they're still low. This is still a low risk, and we don't want to put fear into every woman under 35. You're 30, now you're going to die of a heart attack. That's not what we're saying. But they've looked over a decade at how risks have changed, or how heart attack rates have changed. It's gone up the most in that group. And again, I don't think people know that. I think we as researchers don't know why that is, and I think that's important to know. But one of the risks that being young and being a woman makes you invincible to cardiovascular disease. That's just not true.
Yeah, that is really important. I did not know that. So, some of the risk factors for heart disease, I know you get asked this probably all the time, but could you outline for us some of the most common risk factors and also maybe how our genetics can play a role in our risk for cardiovascular disease?
Sure. So genetic, there is for some cardiovascular disease, I'll say a genetic basis, and I think so we talked about misunderstandings. I think the misunderstanding there is, it's a on or off switch. If you have the gene, cardiovascular disease, and if you don't, then you don't, or maybe you can get it a different way. Um, Genetics are in a lot of ways a lot more subtle than that, and so you may have a gene or a change in a gene that absolutely puts you at risk of cardiovascular disease. And these conditions, a lot of times we call these genetic cardiomyopathies. So this is a gene. The change in the gene causes a change in the heart, and that by itself is enough to cause cardiovascular disease. Those are relatively rare, but they do happen. What tends to happen in most people is they have a family history of cardiovascular disease. And what that means is you'll see, many people or several people in your family who have cardiovascular disease, but not everybody. And the reason for that is you may have a gene or a change in a gene that makes you more susceptible to cardiovascular disease, but you need something else to go along with that. So, for example, if you have a gene, a change in a gene that alters how you handle fats when you eat them, and that you retain more of them in your blood, so that the fats are higher, then you're going to be at higher risk for cardiovascular disease. But you could lower that risk at least a little bit by things like diet or exercise. And again, it doesn't mean that if you lay off of fatty foods that you're never going to have a heart attack. It just means you lower your risk. So in terms of genetics, it's not quite as straightforward as a lot of people think. For other risk factors, I think everybody knows, diet and exercise. Those are two of the big things that people have. In many cases, some control over eating, a balanced diet, obviously, and getting regular exercise. Those are key factors. I think people recognize age as you get older, your risk for cardiovascular disease goes up. But your sex, whether you're males or female, actually is a risk factor as well. For men, that risk starts earlier in life. So when men, enter their 40s, their risk is relatively high compared to women, and it goes up over time. Women, in this sense, lag behind in a good way, that the risk is lower. But when they hit age 50 or so, once they go through menopause, their risk actually rises very quickly, so that they go from a lower risk of cardiovascular disease or dying from cardiovascular disease to a higher risk than men of the same age. I don't think people realize that risk is actually higher in
Mm-hmm. And so what is happening in the woman, I guess? So obviously menopause brings a lot of different hormonal changes. What is happening, I guess, hormonally, but also you study the molecular basis for these changes, right? How
Yes.
can you explain to us what is happening to cause this woman to be at greater risk?
Sure. So I think what most people know or recognize or may have heard of is that estrogens, which are the hormones that are higher in females, they give them their sex characteristics that we generally associate with females in terms of biological development. And so estrogens, which are actually a group of hormones, are relatively high in younger women, certainly compared to men of the same age. And then when women go through menopause, which is actually about a decade-long process. So this is not something where one day you have high levels of estrogens and the next day you have, low levels, which is what happens after menopause. Women go through this transition basically in their 40s, because the average age of menopause is 51. And so what happens is their ovaries, which are the prime source of estrogens, start to change. And over the next decade or so, estrogen levels do generally decline. But what happens actually during that time is that there are large fluctuations in estrogen levels. So they can be very high and then they can be very low. And these can change over a relatively short period of time in women as they go through menopause. So it's not just a loss of estrogens, it's actually a very chaotic change in the hormonal environment in women, where levels are really high and really low. Estrogens change, progesterone changes, several other hormones in women change. The estrogens, we know, protect women early in life. The evidence there is about as conclusive as you can get. That is something that does protect younger women compared to younger men. So when they go away after menopause, it's understandable that risk would go up.
Mm-hmm.
We don't dispute that. We're not saying that doesn't happen. But what we think might happen that people haven't really looked at is that 10 years of very chaotic hormonal changes associated with menopause, we think actually stress the heart and cause it to remodel in a way so that when a woman is now, 51, 52, her heart is fundamentally different than when she was, 40, 41. It doesn't mean that they have heart failure. It's not something that you're going to, go to your doctor's office and have a scan done and they're going to see things. As you mentioned, it's actually inside the cells. And in general, what we're seeing is the heart has a number of systems that allow it to protect itself. So when you exercise and put a stress on the heart, it can change very quickly and protect itself against that increased load, and that's not a problem. If you have high blood pressure, it can try to protect itself, at least for a little bit. In our animal models, so we're studying mice where we induce menopause in these mice, we see a loss of some of these protective mechanisms. And so what we think is happening actually is that woman who's 51, 52, her heart appears normal on the outside, but underneath is changed so that when you put a stressor on top, something like a heart attack, the heart is much less able to tolerate it. So, and that's why we think that women are more likely to die of a heart attack than men. They're not necessarily more likely to have the heart attack, but in the month after a man and a woman have a heart attack, the woman is more likely to die, at least in the group after age 50. And we think it's because the heart is essentially like a house of cards, right? It looks okay. If you stress it, the whole thing falls apart.
And how does a woman's age, so we know that it does vary a bit as to when a woman starts going through, I guess, perimenopause. So if a woman starts going through this at an earlier age, she is at increased risk. Is that right?
Yeah.
How early would be early, or go ahead?
Yeah, no, so there's two categories of what you would just describe as early menopause. So like I said, the average age is about 50, 51. A woman who becomes menopausal before age 45 would be considered to have gone into early menopause. And before age 40, they describe that as premature menopause. And in both cases, the risk of cardiovascular disease that comes after menopause is actually higher than if they were able to wait until age 50. So after age 50, a woman's risk goes up by a certain amount, depending on a number of factors. If she went through menopause by age 45, that risk would go up higher. And if she went through menopause before age 40, it would be even higher than that. So for us, this is, we know, as I mentioned before, that age is a risk factor for cardiovascular disease. The older you are, the more likely you are to get cardiovascular disease. And so it would be easy to say the reason that women's risk rises after age 50 is because they're older than when they're age 40. And that is true. There is some risk there. But by showing that if you go through menopause before age 40, your risk is much higher, that shows us that it's actually menopause itself that's the risk factor here. And so we're trying to separate out what's menopausal and what's age-dependent changes.
Okay. That's very, very interesting. That's a great explanation. So thank you. There are other changes that the body goes through as a woman is going through menopause, and this fluctuation of hormones that you're speaking of does cause a lot of different changes. And one of the changes is in adipose tissue. And I believe that there's a kind of a restructuring, and it's women tend to have a harder time losing weight once they've been through menopause. How does this affect the heart? Is there an effect on cardiovascular health when we see the maybe redistribution? I'm not sure if that's the right term, of adipose tissue post menopause.
Yeah, no, so that's exactly the problem is it's not so much the amount of adipose tissue. I mean, certainly there is a limit, and once you go beyond that limit, your risk for cardiovascular disease will go up. But what we see in women is that after they go through menopause, the adipose distribution, how it's spread in their body, can differ. And so younger women tend to have their largest adipose deposits kind of in the hip region, around the pelvis. And then after menopause, they then start to gain adipose tissue in the abdomen, and what we call visceral. So it's kind of deep in the abdomen. This patterning is more like what we see in males. So they often refer to this as a male patterning of adipose distribution. And so men have a higher risk of cardiovascular disease when they have this sort of fat distribution, and women, as they experience this after menopause. And it doesn't happen to all women, but some can. When they see this redistribution, the risk goes up. And so, like I said, it's not that they're gaining fat, because they might not actually gain fat. It's just that it's distributed differently. And when it's in the abdomen, the fat that's there actually responds differently to signals in the body. For some reason, we're not entirely sure why this happens. It's more resistant to things like insulin. So women can develop insulin insensitivity, which is what happens in diabetes. This is a metabolic problem. If you have a metabolic problem, then you can have problems first in supplying energy to the heart. So the heart can be, I'll say, starved. It's not truly starved, but the energy supply could be hampered. But more often what happens is that the waste products that are produced when we metabolize things are now different, and they become more dangerous to the body. So we get more of these waste products that are produced that can cause damage. We have less of an ability to buffer that in postmenopausal women. So that's part of the risk factor. They have these things called metabolic syndrome, where their metabolism actually changes, and that can actually affect cardiovascular disease.
I guess there's an argument here. Of course, there's an argument for trying to maintain good health even before menopause, right? Because it will set you up for less risk when you do go through these changes, some of which you can't really control too much of, right? I also read about changes in the endothelium that happen. Could you talk a little bit about this and explain this to us?
Sure. So again, estrogens are protective, generally in the cardiovascular system, and one of the things they protect is something called the endothelium, which is basically the lining on the inside of your blood vessels. Your blood vessels are under enormous pressure because they're obviously holding the blood, 24/7. That pressure never goes away. They're subjected to stressors like infections, and when you eat a fatty meal, obviously fats come in, and these can all damage blood vessels. Normally the body has pretty good ability to repair itself, and that's why you don't see a lot of vascular disease like atherosclerosis in younger people, because it's a robust protection. But because a lot of this is driven in women by estrogens, when they lose that, what ends up happening is just the everyday wear and tear on the vasculature can't be repaired, at least not as efficiently as it was before. And this then leads to things like atherosclerosis, so the buildup of fatty deposits in blood vessels, because what they require to form is something sticky to form. And as long as the endothelium is there, it's pretty smooth, and it doesn't allow things to sit. But if you make a hole, it now has a nice little sticky spot fats do to start to form, and that's how you get these clots. The other thing we see after menopause is control of the immune system, or inflammation starts to maybe not go away, but become altered, because again, are good regulators of immune function and things like inflammation. And so after menopause, the ability to control these systems goes away. Those metabolic syndromes that we just talked about produce things that inflame the body and cause immune responses and inflammation. And so the body has less of an ability to control that because the estrogens are gone. And so now what was a minor irritant before that could be easily repaired now starts to build up over time. And inflammation, metabolic waste products, these all start to damage the endothelium, and we see the appearance of vascular disease.
So I want to talk with you a little bit about a controversial topic called hormone replacement therapy. And there's been a lot of discussion about this over, I think, the last about 3 or 4 decades, and a lot of confusion about this. And even in what you were saying as to your in the past, people were saying, well, we already know that estrogen is protective, but no, there's a risk. And there's been a lot going on. So where are we at today with the research on hormone replacement therapy? And do you see estrogen or hormone replacement therapy, do you think it has a role in women's health? And what do you see as a researcher as to some opportunities maybe for this conversation in the medical field, but also among those who may be lay and may be looking for some information?
Sure. So if you go back to the late 90s, what you're calling hormone replacement therapy, which was essentially estrogen supplements, progesterone was given as well, but it was really the estrogens that were the protective elements, were given to a lot of post-menopausal women. It was one of the most widely prescribed drug regimens in the world. And in the early 2000s, there were some clinical trials that showed that estrogen therapy didn't provide the protection that we thought, and may actually cause some risk factors, things like increased risk of hormone-sensitive cancers. And look at the prescription rates for hormone replacement therapy in the early 2000s, over a year or so, it practically drops off the cliff, right? It goes from being very widely prescribed to, almost nobody. So this sounds crazy, but it was actually not an unreasonable response. I mean, if we don't know what the effects are, I completely understand why women would not want to take it, and why physicians or other healthcare providers would say, I don't want to prescribe this. So that's perfectly understandable. What has taken place over the last couple of decades, really, is research into why this happens. How is it that you can have a group of information on one side that says it's protective, hormone replacement therapy is protective, and then information on the other side that says it's not? In both cases, the studies are well done. These are large studies. The results that they find are backed up by the data. So it's not like we can point to one side and say, well, this was a very weak study, that's probably why they found different results. So what we have spent the last 2 decades really doing is trying to figure out why this has come about. One of the things that we're interested in is the idea of timing. So the studies showed, even the studies that didn't show protection, did show that if hormone replacement therapy was applied early in menopause and applied for a limited period of time, which is about 10 years, there was protection, and the risk was generally low. There are certainly some women where the risk will remain high, but for most women, it's low. So we're investigating that. When is that window that we can target women? And so what you're beginning to see now is a cautious return to hormone replacement therapy. And you're seeing women being prescribed estrogens to treat things like hot flashes or other symptoms of menopause, not quite yet as a treatment to reduce cardiovascular disease, because the studies are not there yet. They haven't done those studies where they say, okay, if we only apply it early, or if we give this dose, so a lower dose appears to be better, things like that. What's our cardiovascular risk? And they haven't got to that stage yet.
Okay.
But we're turning there. We're seeing it being given for other things. And there was a statement released in the last couple of years. I can't remember when it was exactly, the Canadian Journal of Obstetrics and Gynecology, where the recommendation is, if you go through menopause early or have a premature menopause, so those are women under 45 who experience menopause, there is the recommendation that they start hormone replacement therapy when they enter menopause, and at least carry it for the next decade or so to the point where they would normally be going through menopause, as a way to reduce risk factors for things like cardiovascular disease. So we're now starting to move it into what I'll say is the highest risk group, because we think the benefits outweigh the risks. And the next step would be, okay, women who go through menopause at age 50, 51, which is when we would normally expect that, can we reduce the risk for cardiovascular disease by modifying how hormones were given previously? So I would say we haven't given up on it. We just need to do more research in understanding how estrogens work, how menopause changes the heart, and how the exposure of a post-menopausal heart to estrogens, how that reaction takes place.
Mm-hmm. And I guess we could reason that the treatment with some type of hormonal replacement therapy could help, possibly, we don't know because, as you said, we don't have the research for it. It could possibly help to lessen some of the damage caused even to the endothelium. It could help with this adipose tissue issue, right? These types of things.
Yeah, so it's already given for hot flashes, right? Which has a vascular component to it.
And tachycardia as well, I think, sometimes.
Yeah, so we're moving into areas. So if you went back to when it was widely prescribed, it was kind of widely prescribed because it helped everything.
Mm-hmm.
And that was, I'll say, not true, only because they started to find out, well, it doesn't always help everything in every single case. Mm-hmm. And much more nuance to it, which wasn't really appreciated at the time because they hadn't asked those questions and looked to those things. And so now we're starting to do this. And one of the things that's come up, which, when you think about it in retrospect, sounds very simple and crazy that no one would have asked this question, but quite often those are the questions that are most impactful in research. And the question is, we know that estrogens are protective in younger women. They have high levels of estrogens. If you take that away, their risk goes up dramatically. So the thinking was, well, if a woman goes through this perimenopausal phase and she loses her ability to produce high levels of estrogens, if we simply reintroduce them, everything will be okay. But what wasn't appreciated was it took her 10 years to get to that point.
Yeah.
Body has been probably dramatically reshaped, not in an outward way that people can tell. Like I said, the heart, we see that the heart has fundamentally changed. And so is reintroducing estrogens at age 50 going to have the same effects as when those estrogens were relatively high at age 40? And our argument is the heart is different. And we've shown this in our studies, that the way the heart responds after age 50 is not the same as it responds at age 40. And so just throwing estrogens back in there was not a good idea, because it's not the same thing. So we need to know what the change is. And then, when do we apply it? What estrogens do we put in? What dose? How long do we put it? Things like that, right? It's not as simple as you lost it, let's put it back, everything will be okay. And that's where the research is really needed.
And I know we already touched on this a little bit, but you kind of came back to the, I don't know if you would call it the restructuring of the heart, but how a post-menopausal heart is fundamentally different than a pre-menopausal heart. What are some of the changes that you see in your research?
Yeah, so we published a paper a couple of years ago, and one of the first things we saw was the ability of the heart to respond to estrogens changed. Okay. So like estrogens are actually a group of hormones. Mm-hmm. And so if you put certain ones in, you'll get a certain response. If you put other ones in, you get a different response. After menopause, those responses were very different. Some we saw no response to the estrogen. Some we saw the opposite response to what you had seen. Some there was a reduced response, things like that, right? So it's the idea that if you simply introduce the estrogens, you're going to get the same effect. We're saying no, you're treating what is a fundamentally different organ afterwards. The other changes we saw were two specific changes that were interesting to us. One of the markers of stress that we look for on the heart was changed. So it indicated that the heart was under some stress and less able to respond to an additional stressor. So that goes to our idea that if you put a heart attack in there now, the woman's more likely to die because she's already at close to her limit. And then we saw changes in inflammation in the heart. So inflammation in the heart is not a bad thing. It's a way the heart repairs itself all the time. There's a certain baseline level there. That's okay. But what we started to see were some small changes suggesting that the heart was moving to a state where it was more inflamed, okay, under more stress. And again, none of this is going to show up in any sort of exam that you do. You're not going to see the heart get bigger. You're not going to see it contract less forcefully or beat faster or any of those sorts of things. It's all going on underneath. And the heart actually changes itself so that everything looks okay. It's when you put that added stressor on top, when you have a heart attack, when women develop diabetes. So diabetes is a huge risk factor for postmenopausal women. Those stressors are more severe in postmenopausal women than they are in similarly aged men because the heart is closer to them.
And so we've talked a little bit on this channel about, we had Carolyn Thomas on. She was telling her story about her experience with a heart attack. And I saw that, I think in some of your research, you've also even looked at how women are treated post heart attack and how the treatments maybe should be somewhat different, or how the approach needs to be more specified to women, how women generally don't necessarily get the same follow-up as men. Is that right? Could you speak a little bit to that? And I think you've actually developed some, maybe a possible treatment for women. I know you have research going on in this area. Is that right?
Yeah, so there's really two areas there. Idea which Carolyn has talked about a lot, how women are treated in the system. So we're not talking about what drugs work or don't work. What we're talking about is a woman presents to the emergency department. She's having signs of a heart attack. How does she move through the system in terms of getting care? I actually teach this in my cardiology class every year. We have a lecture dedicated to this where we essentially follow a woman through the system of care to see where the problem is. And the short answer is it's at every single step along the way.
Really?
So we do know that, for example, women are still, despite the best efforts, don't appreciate their risk of cardiovascular disease. Men don't appreciate the risk that women have for cardiovascular disease, and healthcare workers don't appreciate that risk. It's still underestimated. So a woman may ignore her symptoms because she believes she's not at risk. So that's a failure there of education at the beginning. And again, efforts by Heart and Stroke Foundation, the American Heart Association, they have done an enormous amount of work to improve this, and there have been huge steps, but we still have a big problem. When they present to the emergency department, they're less likely to be triaged correctly. So they're less likely to be recognized as having signs of heart attack, because when you're having a heart attack, there's a saying, time is muscle. The longer you wait to treat them, the more damage to the heart there's going to be. Right? So they should be seen immediately. They're supposed to be given the highest priority, and they're not. When they're suspected of having a heart attack, they're less likely to get the diagnostics to identify them early. They're less likely to get the appropriate treatment. And even if they get appropriate treatment, it's less likely to be at the intensity that it's supposed to be. After they're discharged, they're less likely to have cardiac rehabilitation, to have access to it, or to follow it through to completion. So that's essentially the full scope of care. And we can find problems all the way through. So that's certainly one of the reasons why women are more likely to die, because the entire system fails them from beginning to end. So I teach about that. I've written about that. Things like, for example, how COVID has impacted women differently than men, and how, again, there's a systemic failure there. Our interest in the lab is developing treatments, and there is some debate as to whether treatment should be different for men. And
Right.
there are treatments where if you give it to a man and a woman, they both respond, and so there's no need to dedicate treatment based on the sex of the individual. But what we're seeing, the fact that how women move through the disease process and how disease develops, suggests that there is certainly room for therapies that are directed not only specifically at women, but also at men. I mean, if women are different, that means men are different too. And so their therapy should be tailored to them. And so we've started to investigate this with basically a modified version of hormone replacement therapy, where we give it in a very short window. And what we have found, we haven't published this yet, is the formulation that you use that protects hearts from female animals is different. And actually, in the cases that we've studied, is actually the opposite to what we see in the male animals. So if we come up with some drugs to treat the females, that works. If we give it to the males, it does not. And the drugs that we give to the males do not work in the females. So that's interesting because, one, it tells us there's potentially a need for sex-specific therapy. The other thing it opens up to is our treatments are hormone-based, so they're based on estrogens, and we can give them to males and have a beneficial effect. So the work that we're doing is not all exclusively for females, that actually men can benefit from this as well. And because of the timing, the way we give it, there wouldn't be any of the concerns that you would have in a male who goes on hormone replacement therapy. And if you gave men estrogens for 10 years, there'd be all sorts of problems. But because we give such a short period of time, the males would not actually see any negative effect. So it's the idea that what we're learning in females can actually benefit males as well. And I don't think people appreciate that if you investigate one sex, it can translate to the other.
That's very, very interesting. And so that's what you're working on. That's something you're working on right now?
Yeah.
Wow. Yeah, that's really, really interesting. And also just the challenges that women face in when they do, like you said, present to the ER, and how every single phase that they're maybe less likely to get adequate treatment. How would you suggest, or how do you even talk to your students about this, how maybe women could advocate better for themselves? I mean, I know that a heart attack in women often looks different than it does in men, and maybe that's part of the reason why it doesn't get recognized early, right? It doesn't always present as this urgent, holding my chest thing,
Yeah.
right? How can women advocate better for themselves in the healthcare system in order to get the care that they need? I mean, it doesn't just have to be if you think you're experiencing a heart attack, but just for your general health, or if you have concerns, you have a high risk. What do you see as opportunities, I guess?
Yeah, so I mean, Carolyn, you mentioned Carolyn has been on and talking about this. I think Carolyn's actually a great example of what can be done to help women individually have a background in science. She often talks about that, right? I think her background was in public relations and media and things like that. But what she has done because of her own experiences is learn the science, learn the medicine behind things. And she's not a practitioner. I'm not a practitioner either, but we can all learn enough stuff about various diseases in our own health to understand our own situations. Because whether you're male, female, it doesn't matter who you are. We all have our own unique circumstances. And so the more you learn about your own health or your own conditions, the better an advocate you will be when you go in to see your healthcare professional. So that's one side of the equation. But if you don't have the other side, then essentially what you have is somebody who's viewed as a problematic patient, right? Somebody who's just coming in and saying, I want this, I want that. And so they'll be dismissed. So we need to educate the other side, which are healthcare professionals. And it's interesting because there's been surveys done where they ask women, so patients, do you know what your risk is? And they don't. And like I said, despite the best efforts, they still believe, many of them believe that they're at low risk. But when you ask the other side, you ask physicians, whether it's a family practitioner. So one study looked at family practitioners and cardiologists, and they said, how confident are you in treating your female patients for cardiovascular disease? And a minority of them said that they were confident. And in terms of the cardiologists, it was a significant minority. It was something like 20%.
Wow.
So it's not that they don't. So the message from that is not, well, they don't care. The message is they recognize that they simply don't have the information that's needed to, fully treat their patients. That the information that they have has been gained from studying men for a long time. And so we need to educate physicians and other healthcare professionals about what these differences are, what the latest treatments are, how to talk to your patients, how to listen to what they're saying, and so forth. And so my effort in doing that is by teaching my cardiology class. So I'm teaching them both as individuals, saying, look, those of you who are at risk, you need to advocate for yourselves. Those of you who are men, recognize that your female friends, colleagues, family members are at risk, and you need to help speak up alongside them, not necessarily for them, but alongside them. And many of them want to go on to healthcare. And so when you're now on the other side, recognize that when your female patients come in, their symptoms, their conditions, their treatments are going to be different in many cases than the male patients, whether it's cardiovascular or any other system in the body. But that what you're taught is largely medicine from a male perspective, because that's how we've gained our information. So do your best to understand that and maybe create some knowledge so that we can, advance healthcare across the spectrum for women, not just cardiovascular health.
Mm-hmm. Absolutely. Yeah, that's wonderful that you're doing that to help educate, right? Those that you can, those that are within your reach, right? And that's what we're trying to do through this talk as well. If you had a group of women in front of you, say age 20, 30, 40, and they were looking to reduce their cardiovascular risk over their lifetime, based on the knowledge that you have, what kind of advice would you give them?
So I would build off what we were just talking about, which is advocacy. That the women who I'm talking to, I would say that they need to be their own advocates, that they need to empower themselves with knowledge to understand their situations, understand what their options are, and to work as a partner with their healthcare professional to move through the system and determine what care is best for them, whether it's that they have a condition and they're trying to treat it, or they're trying to prevent something. Because ultimately they're the one who makes the decision. Right? The physician can prescribe whatever they want, or make any recommendation, but if the patient doesn't follow the prescription or doesn't take the advice, then you're going to go nowhere. So understanding what works and what doesn't work, they need to do that. I would say that they all need to recognize that they are at risk for cardiovascular disease, and not in a fear-mongering kind of way. We're all going to die at some point. This is not you're 30 years old, at some point you're going to have a heart attack, and it's going to be horrible. It's just the recognizing that because you're a woman, because you're a younger woman, you're not invincible.
Yeah.
Thing applies to younger men, right? That especially when we're younger, we think this is never going to happen. But that's the time in your life to reduce that risk. And if you can begin to reduce it when you're 25, 30, that when you're 50 and these risks begin to accumulate, it's not overwhelming. So to recognize that we're all at risk and just take reasonable steps to try and reduce it as much as you can. The other thing I think I would point out to them, which I think is something that's come up really in the last week or so, which certainly we've known about it, I just mean it's been highlighted, is the connection between mental health and physical health. Mm-hmm. Disease is a physical disease. We know that, right? We know there are changes in the body, and it can be driven by things like diet and genes and stuff, these physical factors. But actually, one of the significant drivers of cardiovascular disease is mental health or mental illness, and it actually goes the other direction. People with cardiovascular disease can develop mental health conditions. So when you're thinking of a physical condition like cardiovascular disease, you can't simply ignore your mental health. Those things go hand in hand. So taking care of something like your mental health, taking breaks, doing things you enjoy, trying to reduce your anxiety levels. These are all, important for your physical health. And I say that's specific, it's for everyone, but specifically for women, because I think one of the things that we've seen that's really come to the forefront with the pandemic is the mental stressors that women experience. First of all, they're different than what men often do, but they're actually quite high. And I suspect that we're going to see over the next few decades a tremendous growth in cardiovascular disease in women. It's driven by mental health issues because they're not getting the mental health care that they need. They're not recognizing the stress that they're under and the risks that they're taking. And until we address mental health, you're still going to have that cardiovascular disease risk there. So, I mean, those are the things that come to mind, I think, that would be amongst the top things I would throw out to a group of women like that.
That is so important. And thank you for bringing that up, because when we think about cardiovascular health, we're often almost programmed or educated to think about diet and exercise, right? But this issue with mental health and with the stress that women have been under. I mean, I'm a woman, I have children, I've been through this pandemic. I mean, I can completely relate to what you're saying. And it's something that we don't necessarily link, right? That what you're going through and the fact that you're not addressing this could be affecting your cardiovascular health and putting you more at risk, right? So thank you very much. Yeah.
Mental health is health. I mean, it impacts all systems. So it's something that we really need to consider.
Absolutely.
Whatever.
Absolutely. Completely agree. And are there any resources? I know that Heart and Stroke has some excellent information on their website for people who are looking for more information and even information specifically about women's health, women's heart health. Are there any other resources that you would point people to, or even educators that if people are looking for more information, they could go to?
Yeah, so there's a number of national cardiovascular organizations, the Heart Association of Canada, the American Heart Association, the British Heart Foundation. They're all, and have been for a number of years, recognizing the unique issues faced by women in terms of cardiovascular disease. So they all have very good resources, and in many cases, they have people who speak on their behalf. That can speak to these issues across the range, right, from physicians to researchers and so forth. So I would go to those resources first. They're reliable and they're accessible. They're designed not just for healthcare professionals, but if you have no science background at all, you should be able to go there and begin to learn about things. And then from there, you'll see people across Canada and the United States and really throughout the world who are leaders in the field. And then you can, begin to follow them and look at them for advice.
That's great. And Glen, what are you working on right now? What are you excited about? What's grabbing your interest right now in the area of heart health and research?
Yeah, so we're obviously still doing our women's health work. We're looking at long-term issues now with heart failure and why women develop particular types of failure that they do. We're actually just finishing a study now. So after I've done this, I'm going to go work on the paper where we looked at how COVID impacts the heart, trying to find out the mechanisms that the virus, SARS-CoV-2, damages the heart, because we know it causes cardiovascular injury. We don't know how that happens. But we've actually broken out by sex and are looking at how males respond differently from females. We know, for example, males are more likely to die from the illness itself, but females are more likely to develop long COVID, which has a number of cardiovascular issues associated with it. So we're trying to figure out why it is that we see these sex differences in COVID with respect to the heart specifically.
That's great. Well, We will put up the links to some of your research and where people can find you. You definitely go to Heart and Stroke because Glen is on there as well. And thank you so much for sharing your knowledge with us today, Glen. You've definitely educated us on a lot of important factors that have to do with heart health and specifically women's health. So thank you so much for your time today. Really appreciate it.
Sure, thanks for having me. This is important to be able to reach out to people and let them know what's going on. So I appreciate the platform that you're providing here and the time you take to do this.
Absolutely, and I know that our audience will appreciate it as well. So thank you.